This is the fourth part of our lecture on tibial plafond fractures from the Orthopedic Trauma Association Core Curriculum Resident Lecture Series, version 4. These slides are by Dr. Corey Collins, and I'm Saqib Rehman narrating. In our last video, we talked about fixation techniques using plate and screw devices. Before that, we went over all the surgical approaches. In this last video and part of this lecture, we're going to talk a little bit about intramedullary nailing techniques and then also talk a little bit about complications and outcomes. So, nailing is advantageous for a few reasons. It avoids soft tissue dissection in an area where dissection can be deleterious due to poor soft tissue envelope. It spares the extraosseous blood supply. I think it's a little bit biologically friendly. You can also say it's a load-sharing device, although in the distal metaphysis, that's not as helpful. And it is a familiar technique to many surgeons. So, if you have an articular fracture, ream to the depth of the desired intramedullary nail, and if there's no articular fracture, you just got to be careful with these spiral fracture patterns that you don't propagate a fracture into the joint. And if there is an articular fracture, typically you're going to, or at least how I treat it, is I'm going to fix those first. So nailing is not done for grossly displaced intra-articular fractures, but at least in my hands, more often for those minimally displaced fractures, perhaps where you can percutaneously reduce and fix the plafond and then place the nail. So here's an example of a very distal metaphyseal, or I guess you could say metadiaphyseal fracture. I think this is something you could treat with a nail. And this is something that if you are going to treat with a nail, you want to get reduced nicely. Remember, it's just like a proximal tibia nailing in some ways. If you're not careful, you can easily end up in varus or valgus malalignment, depending on where your instruments and eventually your nail falls in the distal fragment. So you have to consider additional reduction tools. You may have to do fibular stabilization to sort of key in maybe a simple fibula fracture pattern in order to get length alignment. Alignment and rotation. You may have to consider temporary plates on the tibia to be used while you're nailing. Clamps, Shan's pins, distractors, blocking screws. Again, the point is, if it's not reduced, you got to do something, and all these techniques potentially may need to be employed at some point or the other in your cases. So, so the OTA, here's an example of OTA A fracture again. A very low oblique fracture. And you look at this and you could say, well, maybe it's too low for a nail. But with a lot of the newer nails now, you can get a few locking screws distally, and he's going to also show you a nice technique to improve your stability with those locking screws. So here you can see indirect reduction. And again, with these indirect and MIPO reductions, the earlier the better. I mean, if you wait 2 weeks, there's going to be enough scar tissue in there. It's not going to close so easily with a clamp. But here you can see nice reduction, guide wire and reamer right down the middle. Okay, and in that case, you're going to be able to get, in this case, almost a near anatomic reduction, and then interlocking screws distally. One you can see is potentially even crossing the fracture site, which may or may not be possible or a good thing, depending on what kind of fracture you're treating. Here's another case, 65-year-old diabetic patient, intra-articular fracture, spiral fracture down the tibia. But the intra-articular involvement is not that significant. So here's a case where you maybe want to be more biologically friendly, treat this with a nail instead of a plate. And this is a novel technique I have not used. Dr. Collins is showing it to you here, in which, again, very important to get perfect nail placement. And again, you may have to, I guess it's worth showing. I think there's a slide on this, but we'll just kind of show this. Remember, if you need to, you may need to place a blocking screw here or both places to sort of make sure this nail comes right down the middle. But look at this. In this case, he's showing you an example of actually using a 1/3 tubular plate and then placing screws through that to interlock to the nail. So, novel technique to improve the stability, and shown here using minimally invasive techniques. So, in general, and this is really with all your peel-on fractures, and we're kind of just stepping back now and looking at the topic as a whole, not just nailing. But you got to elevate them, right, to get the swelling down. They're going to be non-weight bearing. These are articular injuries, and articular weight bearing injuries still are traditionally treated non-weight bearing post-op. But early range of motion, as long as your soft tissues will allow it. I mean, if you truly have a situation where you're very concerned that your soft tissue is going to break down, then you may have to hold off on motion for a while. But otherwise, you can typically do relatively early range of motion. In my hands, I find that I'm not as likely to move them as quickly as I am with tibia plateaus, because I think the knees get stiffer and it's more clinically significant, and the wounds are worse in the ankle, and ankle stiffness is a little less clinically significant. That's my take on it. So these do frequently get stiff, and to prevent that, certainly motion early can help. But most surgeons still are going to be pretty conservative with weight bearing. So 10 to 12 weeks is sort of the conservative party line for these weight bearing lower extremity fracture patterns. Certainly in the ankle joint or knee joint or in the hip. You want to look for signs for metaphyseal healing, and if you're not healing, or if you feel like there's issues of bone loss that haven't been addressed, or maybe if you've done a masculate technique, sometimes you got to come back and do a staged bone graft. So these fractures do have problems. We've kind of been mentioning it throughout the lecture, and these are cases, especially the type Cs. They have low SF36 patient-reported outcome scores, a lot of persistent problems, ankle stiffness, swelling, pain, and when these affect working people, it really keeps people off their feet and potentially remaining unemployed. And complications like these, like osteomyelitis, post-traumatic arthritis, malunion, stiffness, obviously BKs, these are fairly disabling. And as opposed to the tibia plateau, these are more prone to complications that are more disabling, and pain is just a bigger issue. So hopefully, to optimize your outcomes, if you understand the injury, you do your homework, plan ahead, make mistakes on paper and not on patients. And then with your reconstruction, try to execute your plan and make the most of your physical therapy opportunities. So, in summary, with your Plafond fractures, results may improve with continued improvements in technique. Less invasive techniques can be helpful, but you have to be really careful, especially when employing indirect reduction methods, that the joint is well reduced and that you don't result in malunion due to improper indirect reduction methods. Protocols can be helpful, especially if you are staging these, because a lot of people who are going to manage these are going to be on-call surgeons who may not do the definitive management, but if they understand what the staging protocols are, they can help temporize these. And remember, not everyone gets the same treatment. Just based on a fracture pattern, you have to take the whole patient into account and decide what's the best treatment for that particular patient. All right, thank you very much. Again, this was the OTA Core Curriculum Resident Lecture Series, version 4 on tibial Plafond fractures by Dr. Corey Collins, and I'm Saqib Rehman narrating. Thank you very much.